Hello guys, so in this video we are going to study about only the management part of hydroteriform mole. It is a very important topic from Obs and Gynae and lot of times questions are asked from it. Right, so first of all, what is the investigation of choice? I have made this whole topic in the form of fill in the blanks or one word type so that you can remember it well. What is the investigation of choice for molar pregnancy? Right, so investigation of choice is transvaginal ultrasound. If they ask you investigation of choice in follow-up, then it is not TVS, then it is beta HCG levels. Right, what is the gold standard? Everyone knows it, histopathological examination. Right. Now coming to the treatment of choice for H mole. The treatment of choice for H mole is suction evacuation. Right. The treatment of choice is suction evacuation. Size of the cannula should be used is 10 to 12 gauge. Anti-D administration should be done. Right. Anti-D administration in RH negative females is done. Very important thing. What is the management of theca lutein cyst? The management of theca lutein cyst is nothing something else. It resolves spontaneously. Right. It will resolve spontaneously, which means that if you treat the H mole, the theca lutein cyst will be treated by its own. After suction and evacuation or hysterectomy, follow-up is done with beta HCG levels, right? You will check beta HCG for follow-up, and how the follow-up should be done. First, measure the beta HCG levels weekly. First, it is done weekly till 3 consecutive values are normal. Till 3 consecutive values become normal, and then 6 monthly, and then 6 monthly, right? So this is for follow-up. Now a very important note that oxytocin is contraindicated in molar pregnancy. Next point, pregnancy is contraindicated for 6 months following evacuation. And what is the contraceptive of choice in molar pregnancy? It is OC pills, oral contraceptive pills. Following evacuation, the beta HCG levels become normal after 7 weeks in partial mole, and for complete mole, of course, it will be a more time, 9 weeks in complete mole. Indication of hysterectomy in molar pregnancy. What are the indications? The indications of are age more than equal to 40, then you will do hysterectomy, not suction evacuation, you will do hysterectomy. If uncontrolled hemorrhage is present, of course, age more than equal to 40 with completed family. If the patient is not completed family, then you will not do hysterectomy. Uncontrolled hemorrhage, and third is invasive mole, right? So what is the prophylactic chemotherapy given? Is it given to all patients? The answer is no, it is not given to all patients. It is given only to high risk patients, right? The prophylactic chemotherapy is given only to high risk patients. So who are considered high risk patients? First, age more than equal to 40, HCG levels more than equal to 10 to the power 5 international units per liter, large uterus size, and lastly, bilateral theca lutein cyst with size more than equal to 6 centimeters. So what is the drug given as a prophylactic chemotherapy? The drug that is given over here is methotrexate. Very important. You have to remember it. And lot of time question is asked. This is a very important question. Or if jaundice is present, then actinomycin D. Now, coming to the management of choriocarcinoma. As you can see over here, that in this picture, WHO scoring for choriocarcinoma, WHO scoring for choriocarcinoma, there is low risk features and high risk features, right? Like less than 39, less than 10 to the power 3 international HCG levels, being a molar pregnancy, less than 4 months duration, metastasis present in lungs, number of mets less than 4, size of tumor being less than 3 centimeter, and no history of chemotherapy are considered low risk, whereas more than 40, 10 to the power, more than 10 to the power 5 HCG levels, full term pregnancy, more than 12 months duration, liver and brain mets, more than 8 mets, more than 5 centimeter size of tumor, or multi-therapy chemotherapy is given. These are high risk features, right? So based on this low risk, high risk, scoring is done. If the score is less than or equal to 6, if the score is less than equal to 6, then it is considered a low risk choriocarcinoma. In case of low risk choriocarcinoma, single drug chemotherapy is given. And that is methotrexate, right, in low risk. If the score is more than equal to 7, it is considered a high risk patient, right? It is considered a high risk choriocarcinoma, and the treatment is multiple agent chemotherapy, right? And the regimen's name is Bagshaw regimen. So what are the constituents of this Bagshaw regimen? The constituents are EMACO. We can remember it by EMACO. This particular topic I have taken from Marrow, and from where I have studied, so it seems alike. First, E is etoposide, M is methotrexate, A is actinomycin, C is cyclophosphamide, and O is oncovin, right? So these few drugs are given, very important. Now coming to the follow-up part. If the patient is a low risk, has a low risk choriocarcinoma, then follow-up is done for 1 year, right? And how follow-up is done? By checking the beta HCG levels. We know that very well. And if the patient is a high risk patient, then the follow-up is done for 2 years. And how it is done? Again, beta HCG levels. So that's it, guys. This is everything, and all that thing are which is important about the management of choriocarcinoma and HMOL. I have covered it over here. Nothing is left apart from it. Thank you.